All right, so the exam 2 is going to be on chapters 32 through 37 and chapter 39, basically. So I did this kind of in an outline format, and we're just going to skim through. I tried to go through an outline that was previously created by somebody else and kind of just really minimize it down to what you definitely should know for this exam. So starting with chapter 32, chapter 32 is on molecular diagnostics. There really isn't much that you need to concentrate on out of this chapter. For an MLT degree, we don't dive a lot into molecular diagnostics, which refers to DNA. That's kind of something more in a four-year degree, so we try to keep it very simplified. All you really need to know for molecular diagnostics is that it is used for the purpose of identifying diseases, chromosome translocations, and monitoring disease, and that's it. So chapter 32, hey, done with. Moving on. Chapter 33 is on flow cytometry. So the first thing you need to know is what is the purpose of flow cytometry? And the whole purpose is to diagnose a hematological malignancy. In other words, meaning diagnosing a leukemia or a lymphoma, one of those kinds of diseases. So it is an analyzer, and you can determine the types of cells you have through the scatter. Does anybody remember what forward scatter measures? You can type your answer in the little box, or you don't have to. Yep, good, Brenda, size. So forward scatter is going to measure the size of the cell, and side scatter is going to measure what we call complexity or granularity. So basically it measures kind of the insides of the cells. So it'll tell us if the cell has granules and what kind of complexity or like say lobes to nucleus it has and so on. So you definitely want to know what each of those measures, and that's how flow cytometry can put those kind of data together to determine the cells that we are having present. Another thing that flow cytometry does is it determines CD markers. CD markers are unique numbers on cells. And by knowing what kind of numbers are on these cells, we can determine what types of cells are present. The key here is, when you look at cells under a slide, most of us can identify a basal cell from a monocyte and so on. But when you get into those immature cells, a lot of them look alike. They're very big. They all have really large nuclei. They are dark blue. They start looking alike. So that's where CD markers help us differentiate. Is that a lymphoblast or a myeloblast and so on. So here's the key CD markers that you guys really should note. Anything less than 10, so I'm referring to CD2, 3, 5, 7, 8, so on, is a T lymphocyte. So anything less than 10 is a T lymphocyte. CD marker 10, otherwise known as CALA, which we talk about later on, CD19 and CD20 are all B lymphocytes. The marker TDT indicates an immature T or B lymphocyte. CD14 is a monocyte. CD13 and in the 30s, like CD33, is a granulocyte, or you can call it like a myelocytic type cell, so a neutrophil. CD34 and 45 are referring to blasts and stem cells. And CD61 is a megakaryocyte. So does anybody need me to repeat any of those? I know I kind of went through them quickly. Any repeats? I'm sure you're taking notes. I will, again, send this out to you. All right, Brenda, which one? E, 13 and in the 30s, myelocytes. So I'll go back through them real quick as you're writing. So anything less than 10 is a T lymph. 10, 19, and 20 is a B lymph. TDT is indicating both an immature T or B lymph. 14 is a monocyte. 13 and in the 30s, like 33 and so on, is a myelocyte. 34 and 45 indicates a blast cell. And 61 is a megakaryocyte. So if you know these CD markers, you should be able to answer a bunch of questions on the exam just based on CD markers. And when you're looking at case study type questions on that exam, if they mention a CD marker present, just by knowing what type of cell it's attached to, you should be able to rule out or rule in answer choices. on a multiple choice question. So if you're looking at a case study type question and it says, this patient came in, it has these symptoms, blah, 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 and they had a TDT marker positive. Right there, by knowing TDT is always associated with lymphocytes, you should be able to look at your answer choices and pick one of those. Myelocytes are the same thing as granulocytes. It's the same lines. When they mature into the granulocytes. Yep, that's good. That's a good question. Okay, so that is basically Chapter 33, what you need to know out of there. The biggest part of Chapter 33, again, is those CD markers to memorize. In Chapter 39, the big thing I want you to know here is what electronic impedance is. Electronic impedance is something that's used in certain analyzers, that how they count and the number of cells that are present. So basically, there's going to be a small aperture, a hole, and as the blood streams through there, they're going to stream one cell at a time through there, and there's an electrical interference created. And every time it goes through that small hole, it's going to pulse. And they basically just count the pulses to decide how many number of cells are present. That is all electronic impedance is. If you know that definition, you are set. So it's just a type of way that analyzers use to determine cell counts. All right, we're going to keep going here. The next chapter is Chapter 34 on myeloproliferative diseases. This is personally one of my favorite chapters in the entire hematology book. There's only 4 diseases in this myeloproliferative chapter. If you know the 4 diseases and the key characteristics in each, you know this entire chapter. So first of all, let's define what a myeloproliferative disease is. It's basically, if you look at the word myeloproliferative, concentrate on the proliferative part, meaning anything that's an overproduction. So each one of these diseases is going to overproduce certain types of cells. So an excessive production, as it says here in the definition. So we have 4 diseases. We're going to start with our first one, which is CML, which stands for chronic myelocytic leukemia. So if you look at the middle word in CML, myelocytic, that tells you what cells are going to be present. Lots of myeloid cells, so lots of neutrophils, basophils, eosinophils. All those granulocytes are going to be really high. Because it is a chronic leukemia, you're not going to see the blasts. You're going to see mostly immature cells, but you won't see blasts. It's going to have a very high white count, greater than 50, can sit up around 100 a lot of times for many patients. It has the Philadelphia chromosome is positive. Anytime you're in a case study and you see Philadelphia chromosome positive, you should right away go to CML. So saying that we have the Philadelphia chromosome, what are our chromosome numbers? It's a translocation between what 2 chromosomes that makes the Philadelphia chromosome. Awesome, Becky. 9 and 22. Good, Brenda. So chromosomes 9 and 22, still have to know that. We see a decreased LAP score. So remember, your LAP is a stain that we can use. And when we stain it, we count the cells up. In this case, in CML, they're going to have a score less than 20. A normal LAP score is going to be between 20 to 100. So less than 20 is going to be a CML type situation. Above 100 is things like polycythemia vera, leukemoid reaction, and so on. So definitely a decreased lab score is a huge thing to make sure you note in CML as well. And then the last thing I have on here is that people who have CML, they can all of a sudden switch over or transform over into an acute leukemia, or what you can also call a blast crisis. By knowing the words blast crisis, what cells begin showing up if you transform to an acute? Blast. Yep. So I said before, in the chronic stage, there's not the blast. But when you start coming into acute leukemia and they switch over, then the blasts begin showing up. And when somebody switches over into an acute leukemia, their prognosis is worsening and, it's not going to be a good situation. So that's it on CML in a nutshell. The next myeloproliferative disease is polycythemia vera, PV. Basically, in polycythemia vera, if you look at the word polycythemia, poly means many. So I always say everything is many. Everything is increased. For testing, everything is up. Your hemoglobin is up. Your hematocrit is up. You have pancytosis, meaning your white count, your red count, your platelet count are all high. Your LAP score is high, so everything is increased testing-wise here. So that's a pretty simple one to remember that way. If we go on to our next myeloproliferative disorder, it's essential thrombocythemia, ET. This usually occurs in patients above the age of 60. Tons of megakaryopoiesis going on, lots of megakaryocyte development in the bone marrow. Just like the name says, thrombocythemia, an extremely high platelet count. Usually it's greater than like 600, 650, usually sitting up around 1,000. And these platelets don't function very well. But when you're looking at a case study question again on your exam, and you see a very high white or a very high platelet count, make sure that it doesn't have any of the other diseases. Because remember, polycythemia vera also has a high platelet count. So be sure that you can differentiate between the two still. Essential thrombocythemia is going to be a very high platelet count, and it's not going to have some of the other indicators that some of these other diseases have. And then our last, is there a way to tell PV from ET through anemia? There could be. So remember, in polycythemia vera, everything is increased, right? So if you have a case study, you should have white count, red count, platelet count, hemoglobin, hematocrit all increased. If you have a case study that's showing ET and you have a high platelet count, but your white count, your red count is normal, your hemoglobin is normal or low, that would point more to ET because it couldn't be polycythemia vera. That should have a high hemoglobin level. Yep, so I'd be good with that. That's a good question, Brenda. Okay, and then our final disease is myelofibrosis with myeloid metaplasia, otherwise also known as chronic idiopathic myelofibrosis, or you can just say myelofibrosis, because that's the key word on this disease title, is lots of myelofibrosis occurring. It's got an ineffective hematopoiesis, meaning it doesn't develop cells very well. And as a result of not developing cells very well, you're going to get some weird things going on. You still have hypercellularity in the bone marrow. In the peripheral blood, though, we're going to see immature granulocytes, nucleated red cells, dacryocytes, which are what? What are dacryocytes again? Teardrops. Yep. Teardrop shaped. Good, Angela. Yep. Teardrops, shaped red cells, and then some other just bizarre red cell shapes. We could also see megakaryocytes or a micromegakaryocyte pop up in the peripheral blood. That's very unusual. Megakaryocytes should only be seen in the bone marrow, so that's something to note. And then definitely we can use a stain called the silver trichrome stain to see the increased fibrosis here. All right, so any other questions on the 4 myeloproliferative diseases? All right. I see I have some people popping on here, and I can definitely go back and review anything that people have missed later. Okay, chapter 35 is myelodysplastic syndromes. The big characteristic here with myelodysplastic is, again, look at the title of myelodysplastic. I always look at the part dys for dysfunctional. So you definitely see some dyspoiesis, meaning the way that these cells are developed in the bone marrow is not correct. They're very dysfunctional development in the bone marrow. And then cytopenias, meaning cell lines are decreased. So those are the two big key characteristics of myelodysplastic syndromes. And the results of why they have this dyspoiesis is because of these abnormal stem cells and proliferation of mutated cells. So there is a chart in your book. I believe it's in chapter 35. It's on like page 489, I want to say, on myelodysplastic syndromes. If you know that chart and the key characteristics on each one, that should really help. And remember, when we get into each one of these myelodysplastic syndromes, each one can convert over into an acute leukemia. I think it's page 489, Brenda. I don't have my heme book in front of me. That's the page number that sticks out in my mind. Oh, good. Thank you, Kevin. That's really sad that that's the one thing I can remember. Okay. So some causes of myelodysplastic syndromes, anything from like radiation, viral infection, environmental exposure, you know the drill, yada, yada, yada. These things can be linked to a lot of stuff. All right, so getting into the dyspoiesis part, what happens when we don't have correct development? in our red cell line, we have the dyserythropoiesis, meaning that all of a sudden now we're seeing oval macrocytes. That's a very common finding in these disorders. We're going to see microcytic hypochromic red cells, and then we can also see ring sideroblasts in the bone marrow. So if you stain with the Prussian blue stain, that will show the iron granules circling around to make this ring sideroblast. For dysgranulopoiesis, so meaning the granulocyte lines, they're going to see lots of basophilia. Basophilia means just the carrying of that dark blue coloring in the cytoplasm. When you have immature cells, they still have that basophilic cytoplasm coloring, but as they mature, they should lose that. And in this case, they don't. They continue having that basophilic dark blue coloring. They have weird granulation. Sometimes they don't even have granules, and they're supposed to. They have abnormal nuclear shapes, uneven staining. Oh, there should also be a dimorphic red cell population. I'm not sure why that's under dysgranulopoiesis. That should be under the dyserythropoiesis. My apologies. Okay, so if we go to our next slide here, that's going to show you some of these myelodysplastic syndromes. So we have refractory anemia, RARS, so refractory anemia with ring sideroblasts, CMML, and then it can transform over into an acute leukemia. I know I did not put up here the refractory anemia with excessive blasts. There is that one as well. So again, if you look at that chart on page 49, that should be your best friend on this chapter. One quick thing is, I think this was on a written assignment, is what does the word refractory mean again? Hold on one second, Brenda. I'll answer that. Okay, so basically refractory refers to hard to treat or not responsive to treatment. Just so you know, when you see that word, it's kind of a hard word to place. Brenda is asking, should we know the WHO classification? Because the chart on page 489 is the FAB classification. The only thing I'm going to ask on WHO is at the end here on AML. Otherwise, I just picked one or the other. It's a lot of info, it gets to be. And at a 2-year level, we have to pick and choose what we want to know. So going with the refractory anemia and so on, as long as you know the percentages of blasts and ring sideroblasts and some of the other key characteristics, you should be able to determine which disease is what. So when the question poses saying, you know, we have a patient that has less than 1% blast, but greater than 15% ring sideroblast in a dimorphic population, your answer should be RARS. So use those numbers to help you differentiate from them. And in AML, the FAB requires greater than 30% blast in the bone marrow, but Kevin is absolutely right that WHO only requires greater than 20% blast to be considered AML. So that is the one thing I do want you to know about WHO, is that FAB only requires greater than 30% blast, and WHO requires greater than 20% blast to be considered AML then. That is essentially myelodysplastic classifications. The best thing you guys can do for yourself is go back to that quiz. There was a quiz on myelodysplastic and myeloproliferative. Look at those questions, know those questions, and I think that'll really help you. Okay, chapter 36 on acute leukemias. Basically, the prognosis of any leukemia is going to depend on that person's age, their immune status, you know, and the chromosomal translocation that occurs. Some are worse than others. We're going to talk about the FAB classification system, especially on the AML leukemias. So again, how does FAB classify leukemias? What do they look at to classify and organize leukemias? Awesome, morphology, perfect. So FAB looks at morphology to classify. So let's start with our ALL, acute lymphocytic leukemia. So the key word there is the middle word, lymphocytic. So symptoms, splenomegaly, hepatomegaly, so meaning enlarged spleen, enlarged liver, bone pain, anemia, thrombocytopenia, and so on. Who do we find ALL in? 2 to 10-year-olds. Great, Angela. 2 to 10-year-olds, children. Yep. So every time my daughter tells me her bones hurt, it just like freaks me out. All right. So markers to remember for this. So remember back when we talked about CD markers is these will come in handy to tell, is this a B cell type of ALL or is it a T cell type of ALL? So again, CD10, CD19, CD20 are all B cells. The special thing about CD10 is it also can be called CALA. That indicates an immature B cell type of ALL. The CD19 and CD20 are the mature B cell markers. So definitely take note of that CALA. CD10 is indicating the immature B cell ALL. There's a reason it's bolded, just so you know. Also, you can find the marker TDT, because remember, TDT is seen on immature B and T cells. So that'll also be present there. Okay, so now let's get into our big bad boy of AML. So acute myelocytic leukemia. So this is mostly common in people over 40 or in children less than a year. So lots of blast cells here because it is an acute leukemia. We are going to start with the classification system now. You need to know the number, the M number, and what the leukemia goes with for your exam. So M0 is AML minimally differentiated. M1 is AML without maturation. In both of these, you have lots of blasts. M0 is the one that has no hour rods and is actually negative for our stains. But when we get into M1, now we're going to see our hour rods and positive stains for myeloblasts. And so just to remind everybody, an hour rod is a little condensed version of all those primary granules, and it is a key characteristic seen in myeloblasts in AML. And then to remind you, your stains here, myeloperoxidase stain and Sudan black B, both stain AML positive. ALL would be negative on those stains. So just as a reminder back to that chapter. So, okay, going on, M2 is AML with maturation. Now we're starting to see more than just blasts. We're also starting to see some promyelocytes and other cells present. We still have our rods, and now we're also seeing a pickup in the monocyte line. M3 is probably one of the ones that you need to know a little bit more about. This is acute promyelocytic leukemia. So just as the middle word states, we have lots of promyelocytes. You do need to know the chromosomal translocation in this one, and it's between 15 and 17. Tons of hour rods. In fact, so many hour rods that they have a term called faggot cell. A faggot actually refers to a bundle of sticks. So when these hour rods are present, and there's so many of them in there, they look like a bundle of sticks in that cell. That's why they have that term. And then a lot of times people who have acute promyelocytic leukemia also can have secondary to that DIC. DIC is a coagulation disorder. I'm not going to go into it a lot here because in your coag chapters coming up, we talk about it. But just know that DIC is a secondary disease that can come along with acute promyelocytic leukemia. I will give you a hint on this. It's not a very nice saying, but people really remember it. Basically, students in the past have always remembered that 15 and 17-year-olds like dick. Again, I'm sorry if you're offended, but it is one way to remember the saying for acute promyelocytic leukemia. Okay, so moving on. M4 is acute myelomonocytic leukemia. So we see both myelocytic and monocytic type cells. M5, acute monoblastic leukemia, so lots of monoblasts. M6 is our urethral leukemias. There are two categories, subcategories of this. I definitely want you to be familiar with what's in bold here. Acute erythroid leukemia, you're going to see pronormoblasts, which are the blast cells of the erythrocyte line, and you'll still see some myeloblasts. So you have both lines here present. But in the pure erythroid leukemia, there's a reason it's called pure erythroid. It's all immature red cell line. So both pronormoblasts and basophilic normoblasts. So all red cell line, no myeloblasts present anymore. And then our last acute leukemia is M7, acute megakaryocytic leukemia. And just like it's called, you see lots of megakaryoblast. So know your M numbers. Flashcards are a great way to know this. If you put the M number on one side and have the info on the back, you can quiz yourself. And just by knowing the middle initial in each one of these, that really helps point you to what cells are really present in each one. Okay, any questions before we go into lymphomas yet? Do we feel okay? Awesome. Okay. Chapter 37 is all about lymphomas. Remember, the difference between a leukemia and a lymphoma is origin. Leukemia is bone marrow, lymphoma is your lymph system. And just a reminder that lymphomas can be connected with certain viruses, and we'll talk about that on the Burkitt lymphoma. We do have one called here multiple myeloma that I'm going to mention quickly. Multiple myeloma is all about tons of immature plasma cells found in the bone marrow. I shouldn't say immature, just sheaths of plasma cells in the bone marrow. And remember what a plasma cell is. A plasma cell is a B cell that's grown up, basically. It can produce antibodies. And in the case of multiple myeloma, it's producing one type of antibody more so than any of the rest. And it's a very hard thing. We talk more about multiple myeloma. I know there's a class at some point that talks about this, I thought. But anyway, it's a lot of renal failure, bone pain, anemia, that kind of thing. People who have multiple myeloma are always in the hospitals getting transfusions. I remember when I was working in a small hospital, I got to know a couple of ours really well for that reason. Okay, moving on. So when we get into the rest of the lymphomas here, you need to associate whether they're a B cell lymphoma or a T cell lymphoma. So we're going to start with the B cells. Our first B cell lymphoma is CLL or SLL. The difference being that one is in the bone marrow and the other is in the lymph system. CLL is chronic lymphocytic leukemia, so that's the bone marrow part of it. SLL is small lymphocytic lymphoma. So in both, you are going to see lots of small lymphocytes. Remember, this is a chronic condition, so you're not seeing blasts anymore or anything. You're actually seeing lots of small lymphocytes. I know that we had a couple slides of this going in our lab, and they're kind of fun to count because you seriously sit there and hit the lymphocyte button like 95 times. The other big key characteristic here is smudge cells, also known as basket cells. And I have a picture here of one. What a smudge or basket cell is in this leukemia, the CLL or SLL, these lymphocytes are pretty fragile. And when you go to make your smear, they smudge out and they look like this. Once in a while, you might see one of these just by making a smear, but in a CLL or SLL condition, you're going to see quite a few of these, and they're quite characteristic in them. So make sure you note that. And let's see, the next slide is going to finish out our lymphomas. We have our hairy cell leukemia here. Hairy cell leukemia is another chronic type of leukemia. There's a reason I say chronic type of leukemia. It is a B lymphocyte type 1. And remember, it's called hairy cell because they have those hairy or those weird cytoplasmic extensions on them. And they're positive for the trap stain. So the saying goes, trap your hairy monster. So you can kind of connect it together. Another type of B lymphoma is the mantle cell lymphoma. I'm not going to get into that. That's one that you could probably not worry about. Burkitt lymphoma is a B type of lymphoma. So we have, in the Burkitt lymphoma, they have cells that, these lymphocytes that have vacuolated cytoplasm and clumped nuclei. Make sure you know that that is a Burkitt type of lymphoma cell. They have a starry sky pattern to their bone marrow due to numerous macrophages. Their hallmark is a high proliferation rate, and they have been linked with the Epstein-Barr virus. So A through D, they're very important to know for Burkitt lymphoma. Okay, going into our T lymphomas, we have Sézary syndrome, which is has a lot of skin involvement, but there is a very specific Sézary cell that goes with this, and that is a cerebriform clefted nuclei. So basically, the nucleus in the lymphocyte looks like it has a crack down the middle, something we like to call a butt crack cell. So you will see this in a Sézary syndrome. In Hodgkin lymphoma, this is probably the one that most people are very familiar with out of any of these. It's in younger patients. A key cell here that you will see in Hodgkin lymphoma is a Reed-Sternberg cell. It's a large lymphocyte that has two nuclei. I know there's a good picture of this in your book at the very end of the chapter. I don't know the page number on this one, but it's the very end of the chapter on chapter 37 that shows a picture of this. All right, so I think we're going to jump into some questions here that I made, and then we'll go back over anything that people have missed out if they joined later. So I'm going to get my questions here. It's the first time I've done these kind of questions on this. So hold on real quick. All right. So on these questions, the nice thing about these is you can click the answer. It's completely anonymous, so nobody knows who got what right. Thank you, Kevin. It's page 522 to see a picture of the Reed-Sternberg cell. All right. So our first question is, what does forward scatter measure? So make your selection and submit it. All right. It looks like we got quite a few people that answered. So, yep, it is size. So, again, forward scatter measures size. Side scatter would measure complexity and granularity. Good job. All right. What type of leukemia is CALA associated with? Okay. So, ALL, good. So, ALL is definitely the one that CALA is associated with. It's the acute version of the lymphocytic leukemia. So, CALA, remember, is CD10 seen on very immature B cells. CALA is also the one that has the most favorable prognosis for the ALLs. So, if somebody has an ALL leukemia and they have this one that has the CALA marker, it's the best prognosis out of them. So the platelet count in polycythemia vera is what? All right, let's take a look. And it is increased. So poly for many, everything's up for testing. Good. What type of leukemia is M4? Kevin, Becky actually taught me how to do these polls. I had no idea. She's amazing. I would never have known how to do this otherwise, Kevin. All right, let's take a look. And it is acute myelomonocytic leukemia. Very good. Acute promyelocytic leukemia would be M3. Acute monocytic leukemia would be M5. And AML with maturation would be M2. So good job. I do too, Brenda. I like the poll questions and I like that they're anonymous. It makes people feel like they can answer better. All right. What is the characteristic cell, cell found in Hodgkin's lymphoma? I can't talk. Okay, let's take a look. And it is the Reed-Sternberg cell. Good. So smudge cells would be seen in the CLL. A clefted lymphocyte would be the Cesari syndrome. And then reactive lymphocyte. Could be a lot of things, but infectious mono is probably the thing that comes to mind. Thanks, Becky and Kayla. I'm glad you could be here. All right. Which of the following would not be found in CML? What would not be found in CML? According to me, Brenda. You don't actually have to worry about Fab or who on this one. You're thinking on the myelodysplastic. All right, let's take a look. And it would be 20% blast. So remember, it's a chronic leukemia. You're not going to see the blast present here in a chronic leukemia. You'll definitely see eosinophilia, right? Because we're going to see lots of neutrophils, basophils, eosinophils, high white count, and a decreased LAP score. So anything less than 20 would be a decreased LAP score. So all of those very much go with a CML. All right. So list the 4 myeloproliferative disorders in the box. So you can just do the initials. I don't expect you to spell them out. All right, I think we're going to take a look. And it is CML, PV, ET, and then MMM, or you can also call it CIMF. The last one, RA, RARS, and those are actually the myelodysplastic syndrome. So easy to confuse. They're all these initials. But definitely the CML, PV, ET, CIMF, MMM are the myeloproliferative disorders. Good. All right, what myelodysplastic syndrome has less than 1% blasts in the bone marrow and blood and less than 15% ring sideroblasts? All right, let's take a look. And it is RA, refractory anemia. In order to be RARS, it would have to have greater than 15% ring sideroblasts, just for the name of it, refractory anemia with ring sideroblasts. Good job. Okay, what is the key characteristic of myelodysplastic syndromes? All right, let's take a look. Good. It's dyspoesis. Very good. So remember, cytopenia is dyspoesis. Okay, Brenda. Good to know. Well, hopefully you got most of what you needed out of it if you happen to lose your power. All right. Which of the following? Yep, I am archiving it right now, Brenda. So I will send that out. If you want to leave your email address now, you can, just in case. All right. So which of the following is least likely to contribute to death for patients with myelodysplastic syndrome? So this is kind of a tricky question, and there's a reason I posted it on here. So what is least likely to cause death for myelodysplastic syndrome patients? All right, let's take a look. It is actually neuropathy. So organ failure definitely is going to cause something harmful to our patients. Thrombocytopenia and neutropenia both are also going to be a problem. In neutropenia, that's going to leave people very susceptible to bacterial infections. And if you're already immunosuppressed, you're going to have a hard time fighting off those infections. Thrombocytopenia, think of lots of bleeding and stuff like that. Neuropathy means nerve damage. That's going to cause some problems, but nerve damage isn't as harmful to your immune system as the others. So definitely neuropathy is the least harmful to myelodysplastic syndrome. And just like Kevin says, what is the least serious? Well, if it was me, I'd rather have neuropathy than some of the others. All right. A patient has the following results: white cell count of 8.3, red count of 2.5, platelet count of 75. I know I left the units off. I apologize. We have a left shift. A Philadelphia chromosome was negative, a LAP score of 136. And we see nucleated red cells, schistocytes, teardrops, and giant platelets. What is it? So take your key characteristics and rule in and rule out diseases. All right, I'm going to take a look here. So it is going to be the leukoerythroblastosis in myelofibrosis. So it's a tricky thing when you get all these results in front of you. So let's go down each one. So chronic granulocytic leukemia is the same thing as CML. And in CML, you would want to see a Philadelphia chromosome be positive, plus your white count would be a lot higher than 8.3. 8.3 is a normal white count. You'd also see a low LAP score in CML. So that's where we can rule that one out. Idiopathic thrombocythemia is basically the same thing as essential thrombocythemia. So very, very high platelet counts. Our platelet count of 75 here is really low. 150 to 450 is the norm. So we would want to see a platelet count above 600 at least to be considered the thrombocythemia. Nobody chose polycythemia vera, and that's good because everything would be up, and we don't have red cell count, platelet count high. And it is the myelofibrosis. Remember, key characteristics are those teardrops, the nucleated red cells. You can see sometimes a megakaryocyte in the blood. Just bizarre red cell shapes as well could be seen. The leukoerythroblastosis is going to refer to the fact that there is immature like leukocytes. So that's what is meant by left shift, is the presence of immature cells. And then the erythroblastosis is referring to the nucleated red cells seen here. So a left shift in a nucleated red cell kind of indicates that leukoerythroblastosis parts. So hopefully that helps by going through each one of those key characteristics. All right, and our last question, what markers would be found on an immature B cell ALL? All right, let's take a look. Good. It is CD10 and TDT. Both are immature lymphocyte B cell markers. CD19 and 20 are actually the mature B cell markers. So it's kind of tricky there. So 19, 20 is mature B cells, but 10 and TDT would both be on immature B cells. Good job. All right. So that is the end of what I had. What other kind of questions do we have? Yeah, good point, Kevin. I didn't see that. Teardrops on that last review question we just had. Teardrops are automatically with myelofibrosis if you want to look at the 4 choices. Good. So what other kind of questions do we have, or what did people miss? I know a few people joined late. I'd be happy to review anything that people missed out on, or go over any other kind of questions. Yeah, Becky, I could tell you something, but it's being recorded, so I can't. Are we going to have access to your slides? I am going to send out that PowerPoint I use. Yep. So I'll have you guys leave your email address. I don't think I can send out the questions I made, Becky Smith. There's no way to send out these poll questions, is there? I asked if can I send out poll questions? Can these poll questions get sent out or not? They're just in the archive, right? The poll questions will be in the archive. You'll be able to see the poll questions that you're going to be on the poll. I can't hear you, Becky. I'm sorry. It was really fuzzy. All right, we'll just say that the poll questions will be in the archive, and I'll send you the link in the email along with the PowerPoint. Kevin, actually, I just teach them that the myelodysplastic syndromes can even switch over to an acute leukemia, but when I teach AML, I leave it in the leukemia chapter. The only thing I mention is that they can switch over into the acute leukemia and then their prognosis worsens. Does that make sense, Kevin? Okay, awesome. Well, good. That makes me feel better too. Yep. Okay, perfect, Becky. Thanks. All right, any other questions or anything that people want to review? Oh. No. Okay. Well, Brenda, any? Oh, great. Thank you, Rebecca. Yeah, make sure that you leave your email address before I take off here. As far as Angela, Becky Hyde, and Kayla, I'm assuming Kayla, it's Lichtenberger. I have your email addresses. And Denise, is it Denise Sookup? Because I have yours as well. Um, awesome. But anybody else that I don't know, please leave your email just so I can send you everything. As far as Brenda asking memorizing the M0 through M7, here's my horrible answer. It's memorization. There's no way to connect it. Not that I figured. Maybe Kevin has something. So if Kevin has a trick to memorizing which one is M0, M1, M2, I'm not sure. But I just say flashcard it, memorize it. Add one more to the list. Awesome. Hey, those coding pathways are quite fun, I think. Yep, good, Kevin. He likes to draw it out. If you can, whatever it takes to put it visually. I always flashcard because to me, I learn when I make the flashcards. So that's why I always say that. But yeah, I don't have a good answer on that. That is true. It's going to basically go from most immature to, and it just kind of switches. Like M0 through M2 is, immature myelocytic type stuff. M3 is getting into promyelocytes. Then we're switching over to the monocyte stuff. M6 is all about, it just kind of switches lines slowly. Yeah, M7 is biggest mega. See, look at all those tips. Yeah, good. That's a good tip too, Kevin. I told them my M3 tip, and I said, I'm sorry if I offended anybody, Becky. So it is in my PARP. It's in this archive. And two maturing. Good. Okay, you know what? I am not that sick. So yeah, Becky wins. See, my students are getting their eyes open to you guys. Don't impress them that way. All right, I'm going to stop the archive, but I'm going to hang on here.